and more particularly as a tool to help primary care providers, and particularly those that are providing care in rural locations where getting access to specialty care is often extremely challenging. Just really briefly, my name is Daren Anderson. I'm a general internist. I'm a primary care provider, and I've spent my entire career since residency in an FQHC, working in a variety of capacities, both as a provider and medical director and quality director. And I was actually in the National Health Service Corps, which is how I ended up working at the Community Health Center. My health center is based in Connecticut, and I'm now the president and the founder of a nonprofit that we created called ConferMED, which is intended to help take some of the eConsult solutions and processes that we've developed here in Connecticut and make them available to practices around our state and around the country. And I'm going to share a little bit about our lessons learned and do a little bit of discussion about sort of what eConsults are and how they work, and then describe a bit more about ConferMED and the work that we're doing specifically in Indiana. So I'll put my slides up and can jump right in. Right, so our focus is 100% on helping to meet the needs of what we've described in different ways as vulnerable populations, people who, for whatever reason, have difficulty getting access to the healthcare that they need. And federally qualified health centers for 50 years have been providing care to vulnerable populations and meeting a really critical healthcare need, providing high quality primary care, behavioral health care, and in many cases, dental care. Now serving over 23 million people across the country. And not that there isn't still need for access to primary care, that continues to be a challenge for some people, but this has gone a long way to help reduce healthcare inequality in the country. And FQHCs, I would argue, are leading the charge for health equity across the country. But during my time as a full-time provider, I would have been the first to tell you that anytime I need to deal with anybody outside the FQHC, I run into a brick wall. And all of that healthcare inequality just comes right to the front. And that's really the challenge that we've been trying to address, at least in part, is we have a wonderful system aimed to meet the needs of our population in their community. We have, as all FQHCs do, have a community based board of directors that keeps us very attuned to the needs of our patients and their communities. But the rest of the health system that we have to interact with is not, sometimes. So this is an example. This actually is the email that triggered all the work we did afterwards in eConsults and specialty interface. And this was an email from, I think, one of the most challenging positions at a community health center, and that's the position of Referral Coordinator. This was an email to me that was in relation to 2 referrals that I had submitted for a Medicaid patient. They weren't uninsured, they had insurance, but they were state Connecticut Medicaid, need an orthopedist and a dermatologist. And the referral coordinator was British, which is why she spelled orthopedic with an AE, which I always think is interesting. But at any rate, what she wrote, you can see, here's the latest news. Dr. So-and-so at Yale Orthopedics says that all orthopedic referrals from the area that I was practicing need to be sent to a local orthopedist. They're not, Yale, this was Yale New Haven Hospital in New Haven, was not accepting referrals from our town for Medicaid patients. And then she went on to say that Dr. Such and Such of dermatology said he will only see patients if they come from these towns. This patient didn't come from those towns. So as she points out, for me, this means I have nowhere to send my Medicaid patients when they need to be seen by an orthopedist. As for dermatology, they have no place to go. Can my job get any harder? Question mark, question mark, question mark. And as much as we've been hard at work trying to find solutions to this, both on the macro policy level and right down on the practice level, I hate to say this, but this scenario continues to play itself out across the country and even in our own practice. Although we've made some great strides, there are still significant limitations to getting access to specialty care for underserved populations, be they uninsured or Medicaid insured. It's hard to get specialists, and actually in some locations it's hard to get specialist access, even if you have Aetna insurance or commercial insurance. Specialty access is a challenge. And there's a lot of reasons for that we could talk about. We are certainly sending more patients to specialty care than ever. Our job's getting harder. The time we have with patients is getting less. The supply has not kept up with demand. And I was reading, this is a study that came out just last year in JAMA Internal Medicine about dissonance and burnout in primary care. And this actually was written before COVID, so anything that they found about burnout has probably increased 10 times. But before there was COVID, many of us, and I would argue particularly those of us working in under-resourced settings or working with marginalized populations, challenged, felt this sense of, as they described it in the study, dissonance and burnout. And these were two quotes that I pulled out of it that I think are important and relevant. The primary care providers expressed feeling demoralized by work condition, undervalued by local institutions and the healthcare system, and conflicted. And they described this as professional dissonance or discomfort, working in a system that seems to hold values counter to their values as clinicians. And from my perspective, that's exactly what I was experiencing when I got that email. This is a healthcare system that does not share the same values of providing access to people most in need. And that really does create a sense of dissonance and frustration. And for me, it kind of just pissed me off. It was really, it continues to. It's really, really frustrating that our colleagues, for a variety of reasons that we know, structural reasons, reimbursement reasons, whatever, are not set up or willing or able to see the patients that we have and are caring for and need them. And so this is my colleague, Dr. Leche, who's a family doc who's been practicing in my practice for going on 40 years now. And this is how he feels every time he gets an email like the one that I just got. And he and many other of the family docs who work with me contributed ideas and thoughts into the process that we've now gone on to describe and to call ConferMED and eConsults. Because he knew, and I knew, that across our health center, about a third of our patients were being sent to specialists every day. And that number has been increasing. It's been increasing because the number and the complexity of issues that we're tackling as primary care providers is increasing. The number of therapeutics and images and approaches to care that we need to be masters of is increasing. And unless you got something really special going on in Indiana that we don't, the time that we have to do these things is, if anything, decreasing. And so one of the things that we as primary care providers do to address that is we more frequently reach out and send people for specialty input. And what we found is that probably almost half of all of those 35% of referrals that I mentioned don't need the patient to go see a specialist in person to get what's needed. It doesn't mean that I, as the primary care provider, don't need assistance from a specialist. It doesn't mean that I don't need advice, guidance, input, a consult. But it means that sending the patient, hopefully along with a medical record that precedes them, to a specialist to be seen and examined and evaluated, and hopefully to get a note back in my EHR that says what they thought, sometimes not, may not be the most efficient way to meet the needs of that patient at this time. And so, telehealth has been, and as you know, is increasingly being looked to as a solution to providing easier access for patients, and particularly in times of COVID. I just want to emphasize that traditional live telehealth, where the patient talks to the specialist by video, is not a solution to the problem, or at least not a substantial solution to the problem that I've been talking about, largely because there aren't enough specialists to see our patients in person now. And there are even fewer that are willing to see our patients, live on a video conference system. And so, while telehealth can certainly help with some issues, what we've been focusing on is something called store and forward, eConsults, as it's come to be known now. And one of the terms for that is store and forward telehealth, which is a way to provide and to get consults and advice in a way that can be scaled, in a way that specialists can, stack up at the end of the day and then go through and answer and at their leisure, that doesn't involve coordinating a time and a place in a video conference system. For the visits that need physical presence, or where a conversation between the specialist and the PCP is needed, telehealth can be a great solution for that, and in-person visits for biopsies and scopes and things like that. But what we're focusing on is all of those visits or all of those consults where it's not needed, or where there's another way that we might provide services. And that's what eConsults are all about. So I want to just show a little bit of data from a study that we did here in Connecticut at the Weitzman Institute that looked at just how significant the problem is. So we did at our health center, the Community Health Center, Inc., which is a statewide FQHC, about 120,000 patients. We did 1,200 dermatology. We made 1,258 referrals to dermatology. in the year prior to the intervention that I'm going to talk about in a second. And the punchline for this, this chart is that we went back. I had a medical student researcher work with me to go back and look at every single one of those cases and see what happened. 11% of them ever got seen by a dermatologist. 89% never got seen by a dermatologist. And we went in a little bit further and looked to see, well, what were they being sent for? And some of them may have had eczema or had a transient rash, poison ivy, or something that went away, and maybe that's why they didn't get seen. But several of them, and we tracked these down, had pigmented lesions that could have represented cancer or another serious condition, and they simply didn't get seen. And the reasons were varied, but many of them were, they couldn't get an appointment at all. Nobody, like the email that I shared, the patient couldn't afford it if they were uninsured, or they pushed it out so far, 9 months. We had a 9 to 12 month wait for these visits in most cases. By the time that came around, the patient forgot, or the condition went away, or whatever else. But only, you think about all the work that went into scheduling and trying to get those appointments for those 1,200 patients, so that only 10%, 11% could actually get the care that they needed. So we implemented something called not just for dermatology, but I'm using that as an example, called eConsults. And this is what an eConsult looks like for dermatology. The same referral question, 30-year-old, here's an example, 30-year-old male with no significant past history, with 2+ weeks of rash, new spots appearing daily, was recently treated for strep pharyngitis. This was in 2018 with 10 days of penicillin, completed treatment. He took penicillin in the past with no reaction. He has a history of psoriasis. This is, as he put it, an e-derm referral. And 12 hours later, this response was sent back in his electronic health record with clear outline and statement of what this was. Strep is a well-documented precipitant of psoriasis, which is an inflammatory flare that's often very treatment responsive, sometimes can set up a more chronic disease course, goes on and talks specifically about what to prescribe, how to treat it, and then goes on to give some advice about what might happen, some contingency plans if the issue comes back, et cetera, et cetera. 12 hours later, this consult was resolved and the patient was treated effectively. When we implemented this at scale across the entire health center, we went back for a year and looked, and we saw about the same number. We sent about the same number of consults as we did before, 1,129 in this case. 66% were completed either with e-dermatology or with an in-person visit. And the reason this wasn't 100% is even with the system I just described, there still were a significant number of patients who needed, for whatever reason, to be seen, for a biopsy or a skin check or things like that. But from 11% to 66% in 1 year, we were reasonably happy with that, and are really now working on the second part of that, where what do you do when you do need an in-person visit, and an e-consult is not sufficient. And so since that time, we built a system that did essentially almost exactly what you just saw, and with other specialties without pictures, to deliver e-consults, connect primary care providers and specialists electronically, rapidly, 24-hour turnaround like I just showed. And we set it up for specialties across the state and over time across the country. And then we did a lot of research, and I'm not going to go into the research. I'm not going to share the papers. I'm happy to for anybody who's interested. But basically what those papers, not just ours, but many others, were studying similar systems like this. And now after more than 10 years of this type of e-consult intervention being in place, there's really now a preponderance of evidence from the literature suggesting that doing what we just did and just described at the micro level with Derm improves access, reduces wait times. It expands what we can comfortably manage in primary care. It lowers cost in a variety of ways. It reduces unnecessary visits. It reduces the need for follow-up visits because patients come better worked up. We showed in one of our papers in the Annals of Family Medicine that it actually lowered ER use, and it reduces unnecessary tests and procedures that often accompany a visit into the specialist. It allows more care to be provided for patients in advanced primary care medical homes, and it increases convenience and satisfaction for patients because they can get cared for in their community by the primary care provider who knows them in more instances than they could have before. So I want to pause and just ask if there's any questions before I get into kind of the nitty-gritty about how does it actually work. If a practice wants to set up e-consults, who pays for it? How do you submit them? All that kind of stuff. I'll take the slides down just for a second and just pause and ask if there's any questions. And do also, I have the chat open, so if anybody wants to ask anything in the chat, you're welcome to submit your questions that way. All right, so let's get into the nitty-gritty of sort of how does this work? And I will say, you know, eConsults have gone from kind of a nifty newfangled thing that a few people were trying to a really an established CMS recognized element of telehealth and type of care that's now being provided across the country in a large variety of practices, but probably more common in FQHCs, rural health practices, migrant clinician, farm worker clinics, places like that, where the need is particularly acute. But basically what an eConsult is, as you kind of could glean from that example that I shared, is a complete consult note that's sent electronically to a specialist, which includes PHI from the patient's chart, so that with a formal consult note in response. So it's a formal consult note from a specialist, the only difference being that this is asynchronous and it's peer-to-peer, and that's an important distinction. So the specialist is reviewing what the primary care provider has done, what the primary care provider is thinking, what tests they've gotten, and is sending back advice back to a peer, in this case, a primary care provider, back into their EHR. And the way we've set it up, and think is really important, is it has got to allow the primary care provider to do this in their EHR. They need to order the consult just like they order referrals now, and they need to get a consult note back in their EHR just like they get referral notes back now. And that's essentially how we and many others have set up eConsults to work. And we work with all EHRs. We have probably 8, 10 different EHRs that we're working with around the country now. And you know, each of them have a slightly different approach, but we engineer it with the practice to make sure that you as the clinician can order it out of your EHR, and that note comes back where you want it to be, in your document inbox, or wherever you're used to getting reports in from outside consultants. The process has got to be integrated into your workflow, and it's got to be HIPAA compliant, and it is. One of the things that we've done, since our focus at ConferMED and at CHC really has been to work with what you got. A lot of the practices that we work with are very rural, very remote. Some of them are very small. They don't all have the fanciest Epic infrastructure, Epic EHR and things like that. And so we've taken a really pragmatic approach to this in opening up a variety of channels for those consults to come into ConferMED, which is our, as I mentioned, which is our eConsult program and process that we've actually launched in the last year in Indiana. We have some practices that are accustomed to using eFax out of their EHR. And so we have a fax number. You can fax us a consult request and we'll put it in front of our specialist. We have a Dropbox secure function that allows you to drag and drop the derm images or the consult note into a box that's specific to the health center, and that comes into our system. We can do what's called direct messaging. If any of you have ECW, that's ECW P2P, for example. Increasingly, we are with a team of referral coordinators that we've hired on our end, are helping within your EHR to work with you to support the referral process and help get the documents out that we need and put the documents back that you need. Because we're finding increasingly, and particularly with COVID, that referral coordination departments or people were never the most heavily resourced parts of health centers. And since COVID, it's even gotten worse. So we provide a referral coordination team that can help with that aspect of it. In some instances, we're working with referral management systems as well. But however we can get the information from the health center, that's the process that we follow. So we're relatively new to the state of Indiana. We've been working, we're in 22 states now across the country, and we launched Indiana last year. And are happy that several Indiana Medicaid payers are now reimbursing and covering the cost of eConsult, so we can deliver them to FQHCs and other Medicaid providers without charge. And we've started building a network. We have across ConferMED across the country almost 300 specialists that work for us in 40 adult and pediatric disciplines and subdisciplines, specialties, subspecialties. We've started a little more narrow, and since Indiana is new and we don't have that many consults yet, we've started with what we call our core 15, which are the 15 or so most common, most requested, most needed specialties on the adult side. And as we grow, will likely build into pediatrics and some of the other less commonly utilized specialties. But as of today, these are the specialties that are available to Indiana providers through a variety of payers and through ConferMED. We credential them, we train them, and I have a team of family docs and myself who monitor their quality really carefully and give them feedback, making sure that what they're providing is useful, effective, and helpful for primary care practice. So this is my colleague, Dr. Leche, who I shared, and I'm just going to kind of walk through the workflow a little bit just to explain sort of exactly how it works. And we customize this for each practice, but this is a general overview of how we like the process to flow. We work with each practice to allow a primary care provider to, let's pretend we're doing a cardiology eConsult. In the EHR, Dr. Leche in this picture is actually using ECW. When he goes in his treatment section to order meds, to order refills, to order labs, to order a referral, he has an option for what we call eCardiology. And when he chooses that, that gets routed to us directly out of ECW. It goes to one of our referral coordinators. This is Haley, who leads our referral coordinator team. She gets in her inbox a new referral from ECW coming in from, in the example here, from the state of Connecticut or from somebody in Indiana. And she manages those queues and routes it to, in an Indiana example, the Indiana licensed, Indiana Medicaid enrolled, Indiana-based provider in that specialty that Dr. Leche requested. That specialist gets pinged. They get an alert by text or email saying you have a new consult. Within 2 business days, and in most cases on the same day, 80% of the time our specialists respond on the same day, within 24 hours. But they get pinged, they log on to our secure portal for specialists at ConferMED, and they view all of the information that was sent over. That if it's dermatology, that includes the photos. If it's cardiology, in the example that I used, it would include an EKG, possibly 6 months worth of labs, and the specific question that the primary care provider submitted and the details of the case from their note. Really, the note and the question are the most important parts of that, because the note is really where the primary care, where the reviewing specialist can get a sense of what's been done and what the PCP is thinking. They type their response, it gets formatted and sent back, and we route it back, in this case, into Dr. Leche's document inbox, where he can open that and view the recommendations and the suggestions that the cardiologist had for him to apply to that case. If the specialist feels that a face-to-face visit is warranted or appropriate, they'll state that outright, but they won't stop there. They will give advice and guidance. What should you do in the meantime? We all know that even if you do recommend a face-to-face, it's not going to be tomorrow. They'll recommend, first of all, how you should manage things in the meantime, or if a specialty visit isn't possible, they'll give contingencies. And they'll also recommend what workup you might want to do in advance so that when the patient gets to that face-to-face visit, they have everything the specialist needs to be able to take maximum advantage of that visit. So we've now done this and set this up in 22 states across the country. We've just this past week added Mississippi, North Carolina, Michigan, and South Carolina to our list, which we're excited about. And the point is, we love maps and we love states, but the point is that every one of these states and every one of these practices has a slightly different payer environment, has a slightly different approach to their EHR. And so we work with every health center in every state to make sure that we're able to work within your environment and provide you what you need. We've done this now 60,000 times. That transaction that I just walked through has happened 60,000 times across the country with a large and growing number of specialists. And 70 to 75% of those consults have prevented what otherwise would have been a face-to-face visit request. And it says here, the average, they've been turned around in 17 hours. We do get detailed survey feedback from our providers. We ask them to rank the services that we provide. We also ask for specific comments, and we're learning a lot about what our PCPs want and what they need. One of the pieces of feedback that we got a few years ago was that PCPs wanted the ability to quickly and easily ask a clarifying question if they weren't clear or they wanted to follow up from the consult. And so we've created a process we call direct dialogue, that allows them to log straight into the platform and send a question straight to the PCP without having to go through the whole consult referral process again. And when we do that, when they do that, they get an answer directly back from the specialist that also comes back to their EHR. That's direct dialogue. We also learned and heard from providers that they wanted an easier way of submitting dermatology consults. And many of them liked the idea of using smartphone technology or using other sorts of tablet devices. And so we've created a way that you can pretty easily put a web link onto the home screen of an iPhone or an Android phone that allows you to capture images in a HIPAA compliant manner that import directly into ConferMED so that you don't keep any PHI or images on your phone. But we receive that along with the data from your practice so that you can get a quick dermatology consult back, similar to the one that I showed in the example. So I'm going to take these down, and I was hoping I can talk about eConsults all day, but I think as the concept becomes more commonly recognized and utilized, questions come up. We do a lot of customization, and I'd love to take any time that you might have to answer any questions. We're going to talk about any of the things that I discussed in more detail. So let me pause there and ask if there's any questions.
We did have a question about, is Veterans Affairs tapped into this at all?
So I actually worked at the VA. I was the director of primary care for VA Connecticut for several years. And the VA does have a version of this within the VA. They have their own internal version, as everything. The VA does everything uniquely and on its own, but they do. They have an EConsult program within the VA that VA providers, both at their VA health centers and at CBOCs, are able to participate in. They also have, since they have their own internal specialty network, a lot of them have specialists working in even some of the remote CBOCs and places like that. But yeah, in fact, in my time at the VA was one of the places I learned a little bit more about this process and adapted it to the FQHC world.
Okay, we have another person say, fellow National Health Service Corps alum here, yay, and current doctoral student. Would love for you to share your research papers, especially regarding the efficacy of asynchronous services. How could we get those?
Yeah, no, I'd be happy to send them along and talk a little bit more about them. I wasn't sure that sometimes with presentations like this, people are really interested in research. Other times they're not, but I'd be happy to share those papers and go into any detail about them. I will say the first study that we did, which was in the Annals of Family Medicine back in 2017, was a randomized controlled trial where this was really our first foray into eConsults, and we really needed and felt it was critical to, obviously, to prove that this worked and that it was safe and effective. So we did a really robust study. We took all of our primary care providers across Connecticut that worked for the company, and that was about 80 providers at the time, and we randomized them. Half of them had the eConsult access, turned on, if you will, in the EHR, and the other half didn't. They got to do what they wanted. They got to choose if they wanted eConsults or not. We didn't force them, but they had access to eConsults, and we did it for one specialty. We started with cardiology, and those primary care providers who were randomized to the intervention group got to use cardiology eConsults whenever they wanted to. We encouraged them to, and we reminded them and things like that, but they weren't forced. And after a year of running to see what happens, the study showed that 69% of all of their referrals to cardiology were managed with an asynchronous eConsult and didn't need a face-to-face visit. And we went on to show, when we studied sort of what happened afterwards, was that the patients cared for by providers who had access to eConsults had 3 times less use of the ER than the patients who were seen by providers who didn't have access to eConsults. And we did a follow-up study that was in the American Journal of Managed Care, where we got claims data from Medicaid to sort of see, well, what were the cost consequences of that, and what was happening on the specialty side. And that paper showed that Medicaid saved an average of almost $400 per consult, or per patient rather, when eConsults were provided. And the main reason for that was fewer tests and procedures. And this made a lot of sense to me as a provider. I know that when I send a patient to a cardiologist, they almost invariably get an echo and a Holter and all sorts of tests. And sometimes those are really important, sometimes they may not be necessary. And that was exactly what the study showed, that patients managed by a primary care provider supported by a cardiology through asynchronous telehealth had fewer expenditures and fewer ordering of tests and procedures, and that overall outcomes, emergency room, urgent procedures, MIs, things like that, were no different in the two groups. So there were no negative. That was the other part of the study that was really critical, make sure that people weren't having heart attacks when they got a cardiology eConsult. And we went through and very clearly showed that outcomes were the same in both groups, but the efficiency was markedly improved in the group that got the eConsult. And then final study that we published in Health Affairs in the final year in 2018, the following year, showed that the same sort of thing was happening for other specialties. We had a GI, orthopedics, dermatology, endocrine, showed that when you keep more patients in primary care, you improve access, you reduce wait times, and you save Medicaid money. And we focused a lot on money. For a lot of reasons. The obvious reason is that we need someone to pay for these sorts of things. We needed to make the case for Medicaid that this should be considered a reimbursable service. It's providing service and value to patients. It's helping primary care, and it's saving the payers money. So we took these data to Connecticut Medicaid, and they became the first Medicaid agency in the country to authorize reimbursement for eConsults. Now, I think it's 26 states provide some level of reimbursement for eConsults through Medicaid, and CMS has authorized for Medicare reimbursement for eConsults, and many commercial payers now do as well, including MHS in Indiana and Anthem in Indiana as well. Augie, there's a third as well. Care, I'm blanking on the name, but we have a third payer in Indiana now, right?
That is correct. We are piloting with CareSource, so hopefully they will be expanding as well. Great.
Yeah. So and as time goes on, it's less hard to make the case that this is something worth reimbursing. I mean, it solves a lot of issues. It improves access for patients with limited access, network adequacy, as they call it in the payer world, and it saves money for the payer, and it makes patients' lives easier and better. And so it's still something new. And so we continue to battle, if you will, state by state, but it's becoming increasingly recognized as an important additional type of telehealth service. So I know that was a really long-winded answer to could we have your papers, but I figured I'd take a little time to go into a little bit of detail, and glad to send them on after the meeting here today. And I will send that there was a Milbank quarterly review of eConsults from a variety of different settings, not just about us, and actually we were one of them, but there were several others. I'll send that summary as well, which kind of gives that summary of the literature that I put up in terms of what's now known about eConsults.
Okay, yeah, Kristen, we have your email, and we'll be able to forward those on once Daren sends them over to us. I'm not seeing any other questions at this time. We will go ahead and give it another moment or two if anybody wants to submit any. In the meantime, I just want to thank everybody for their time today, especially Dr. Anderson for his fantastic informational presentation. Certainly a lot of connections we're going to be able to forge out of this just based on the questions asked today. So just want to thank everybody for their time. I hope everyone has a great afternoon, and we'll leave it at that.
Very good. Thank you. And I do feel free if anybody wants to talk more about eConsults or hear more about what we're doing in Indiana or anywhere, please. I don't remember if I had my email on the slides, but if not, I'm happy to set up a call with anybody who wants to learn a little bit more. Augie and I are both ready to jump on a call anytime you'd like.
Okay, thank you very much.
Sure, my pleasure. Thank you.
It looks like Amy did request his email there, Augie. If you'd be able to provide Dr. Anderson's email.
Yes, I'm just going to put his email in the chat here.
Yes, thank you very much.
You're welcome. And again, we are very happy to speak with anyone, and we're grateful for MHS and Anthem for covering the cost of eConsults. And I just put Dr. Anderson's, Daren's email right in the chat there. Thank you so much.
Thank you. Have a good day.
You too. Bye-bye.